welcome to this very special edition of the Pediatric Epilepsy Podcast, Beyond the Diagnosis. Today we'll be diving into Neuro-Psych evaluations and the impact they have on education and individual education plans for children experiencing pediatric epilepsy or other kinds of neurological challenges, to say. We are joined by really an all-star cast of professionals, and it's my pleasure to introduce them to you. Dr. Z. Mary DuPont is world-renowned epileptologist, has worked and led comprehensive epilepsy centers, and is now a professor of neurology at University of Wisconsin-Madison. Dr. Brenner is a neuropsychologist who works out of the University of Virginia and works in comprehensive epilepsy centers, particularly with youth. And Dr. Mary Wojnarowski works at the University of, Nationwide Children's, and she earned her PhD at University of Alabama. And thank you all for being here. And before we get into the questions, I just want to kind of set the context for Beyond the Diagnosis. Mickie's Miracles, our primary mission is to work as an advocate for families with suffering from epilepsy. And we advocate that they get into a level 4 epilepsy center as urgently and quickly as possible for diagnosis and treatment. We've also learned that a diagnosis and the beginning of treatment is just the beginning of the journey for a family dealing with pediatric epilepsy. So we developed Beyond Diagnosis to really be an opportunity for parents to have awareness of what they can expect. In episode 1, we dealt with medication, measurement, and monitoring. And we had a very robust conversation about that with the Danny Data organization, with a very powerful and influential warrior mama who cares for Warrior Owen and Dr. Z, and certainly our CEO and visionary founder, Christy Greaves. And today we're diving into evaluations and how they impact behavior, how they impact educational future, and really how to best prepare parents to advocate for their children with this information. So I think we'll start with Dr. Z. I always start with Dr. Z. I love to pick on her because it goes back so long, and also because, and as she always kind of is very humble about this, but she literally saved Mickie's life. For those of you who don't know the story of Mickie's Miracles, it was founded in honor of Mickie, who had basically a hemispherectomy one day before she turned 1, and had a third of her brain, basically her left temporal, occipital, and which other lobe, Dr. Z? Parietal lobe removed. And many before Dr. Z said she might not walk, she might not talk, she may not even survive. And here she is, 11 years old, seizure-free, a very sassy 11-year-old with a wonderful personality. And anyway, so that's for our intro to Dr. Z. So Dr. Z, I'd love to hear, because when we were kind of putting together the program for Beyond the Diagnosis, we decided that the Neuro-Psych and how it impacts, their educational and their behavioral future of that child, really was an important topic for parents. Mm-hmm. Can you kind of shed some light into why you thought it was so important for us to dive into this?
Well, I deal predominantly with children who have difficult to control epilepsy, but even children who have epilepsy that affects one part of the brain, their cognitive abilities there can be an impact on cognitive abilities depending on the type of epilepsy, the type of seizures, the frequency of the seizures, what their background activities look like. And so I'm always trying to be proactive in making sure that we are not missing sometimes what can be very subtle learning issues, and some are more profound and overt cognitive impairments, intellectual disabilities, and of course, motor abilities. Those are more obvious. But the way a young child thinks and a baby thinks is a little more difficult to tease out. So I like to be proactive and be ahead of the game. And certainly we know that children who have difficult to control epilepsy, what I will call intractable epilepsy, there's an impact on their growth and development. And I explained this in the first our first webinar, is that when you have a young baby, their brain is not fully formed. It is, they really are working on their brainstem when they're young babies. In fact, you can have a young baby that looks and acts like a normal baby who doesn't have any hemispheres. As long as their brainstem is working, they're going to have a root, a suck, a moral. They'll be able to eat and breathe and act and move their arms and legs. So between zero, they're at birth, and then think of a 2-year-old, and those of us who are children know that 2-year-olds pretty much can dictate what a household does, and they're very good at speaking their mind and being a little manipulative, can run away, can do all these kinds of things. So between 0 to 2 years of age, there's a lot of developmental work that the brain does. There's programmed apoptosis, which means programmed cell death because we're born with too many brain cells. There's programmed synaptogenesis, which means there's ongoing connections that are being made between brain cells. And then there's myelination, which I liken to the insulation around an electrical cord that helps electrical impulses be transmitted very rapidly. So all this developmental work is going on between 0 to 2 years of age and beyond, but very important brain work is being done. And if in the midst of this, you have an ongoing epileptic storm, things don't transpire the way they should. And it's as if the brain gets hardwired for continued seizures, and there's heightened epileptogenesis or excitatory neurotransmitters at the expense of inhibitory neurotransmitters, and there needs a balance in order for the brain to work appropriately. So the brain gets hardwired for continued seizures, and it's a setup for ongoing cognitive difficulties and motor difficulties, etc. So in many ways, I see the brain as having greater plasticity. Hence, when Mickie had her brain surgery, we were able to take out that portion of the brain that was part of the electrical storm, and the rest of the brain could help compensate for that in ways that an adult brain cannot. But on the other hand, that plasticity that's the good side. The bad side is that developing brain is more vulnerable to the effects of epilepsy. So we always have to be proactive, I think, as a pediatric epilepsy specialist to help parents, because the educational system, with all of the recent cuts in public education and teachers and children with special needs, get kind of lumped together in this group. And you all are going to be in this classroom, even though there may be very significant differences in their cognitive abilities and learning styles. And so parents have to be really proactive and ahead of the game and be able to work with the school system. And that can be overwhelming. It would be overwhelming to me as a parent to not only have to deal with a child who there are a lot of medical issues, but also then have to fight insurance companies, have to be a warrior, if you will, or proactive with the educational system. It can be just exhausting. And that's where I rely heavily on neuropsychologists to really do this evaluation and help guide the school system and myself in how we can help this young child be the best that they can be.
Thank you, Dr. Z. And I think now we all know why I always start with her. We've had these conversations many times, privately, publicly, and I come away learning every single time. So thank you, Dr. Z. Dr. Brenner, how does that, first of all, I think folks at home, I'd love to hear, what a neuropsychologist does, right? Because, we deal with a lot of, terms of art in epilepsy, and sometimes, just understanding, the different resources available to parents is important. So maybe we can start there, and I'd love to get your reaction to Dr. Z's response.
Very enthusiastic reaction to Dr. Z's response. A really nice summary and kind of lead into this discussion. So neuropsychologists have specialized training in the brain, but then also in what it does. And so thinking, language, motor function, as Dr. Z mentioned, visuospatial processing, emotions, so emotion regulation, attention, And so what we do as part of our evaluation is to capture the strengths and weaknesses of the child in a lot of different domains. And that's part of why this more comprehensive look at the child or picture of the child can be helpful, because it extends beyond what the school would do as part of their evaluation to really understand how the medical condition is impacting the child. And then just even aside from the medical condition, what are they good at? What's their learning style? Where do they need support the most? And then we can track their progress over time to see how the different interventions, the medications, the therapies, how they're working, and where we maybe need to add something else or increase the dose in the sense of, maybe they need more time in with reading or whatever it may be. So we really provide that more comprehensive picture of brain function and how this is impacting the child.
What goes into, Dr. Brenner, into these evaluations? Like, what are you looking for? How do you assess it? How do you measure it? What tools do you use? I mean, this sounds like pretty profound work, and in many ways sets the foundation for, the next, at least 16, 17 years of a child's education. So I'd love to hear kind of some of the tools and techniques and even, technology that you might use, what you're looking for.
Yeah, that's a good question. So it always starts with a really good interview. So we have a lot of time set aside at the beginning to get to know the family. So we really want to know a lot of the history. So we have access to the medical record, or at least most neuropsychologists do. I certainly do a very thorough review of the medical record. And then I have a conversation with the family, with the child. I'm looking to understand the history up until that point, what concerns they may have, what the family situation is like, what their resources are like, how the child's been doing in school, how their learning has been up until this point. And then the tools we use when we see a child, so they're typically called tests, but I know for most people, you get this idea of, a Scantron, bubbling in, answers, and it's not like that at all. We have blocks, and we ask the child to build with blocks. We ask them to look at pictures, point to pictures, answer questions. We have, pegs that fit into little holes so we can look at fine motor speed and dexterity. So for most children, this is, at times, can be boring, but most of them enjoy themselves. They're short tasks. They get a lot of reward in the sense of we praise their effort, we give them stickers. So for most children, and they get one-to-one attention for an extended period of time. So for most children, this is much more enjoyable than what comes to mind for most people when they hear the word test. And then the final piece of that is that there's a feedback with the family. So we spend a lot of time talking about the results to make sure that everybody's on the same page and they understand.
Dr. Mary, I know that you work primarily with children who have epilepsy, and you work basically in the assessment side as well, and even in some of the kind of short-term treatment, post-assessment, although, that's not where you focus your work. I'd love to hear kind of your perspective, and maybe start by explaining the difference between, a clinical psychologist and a neuropsychologist. Where is there overlap? Where is there differentiation? And then kind of weigh into, what we're talking in terms of assessing a child and the impact that it has on his or her future, and how to arm parents on how to use the information to become an advocate for their child.
Sure. Yeah. So I'm a clinical psychologist by training, and then I've really specialized in child development and neurodevelopmental conditions like autism or intellectual disability, ADHD. So I complete a lot of neurodevelopmental evaluations. So I would say I'm more often seeing young children with early onset of epilepsy, early risk factors for developmental delay and autism, or older children who are significantly or profoundly impacted by epilepsy. So they may be older, but they're functioning at a much younger age. So I would say The purpose of a neurodevelopmental evaluation is really similar to a neuropsychological evaluation. We're really trying to understand a child's overall developmental and behavioral functioning. We're really looking to characterize their learning style, their strengths and weaknesses, what sort of interventions or services that would be beneficial for them to help accelerate their development. I know you asked me several other questions, so
no, you did great. You answered them all.
Yeah,
well.
I'd be interested to hear Dr. Brenner's perspective. At my institution, we have a very large neuropsychological department and a very large neurodevelopmental department. So I think we often end up seeing kids with autism or developmental delays or more significant impairment where other children with epilepsy or neurological conditions may be going to a neuropsychological evaluation and doing that full battery, whereas some of the kids that we see in our department, those measures would be really challenging for them developmentally. So I think that I'd be interested to hear your perspective on the difference between those two.
Yeah, so I will say I often see the same children that you're seeing, and one of the beautiful things about an assessment battery is that it's personalized, right? So it's not one size fits all. It's really designed to meet the child where they are, to understand what they can do, and so that's exactly right. So depending on the ability level, the age of the child, sometimes what I do is more focused on developmentally where they are, intellectually where are they, adaptively, and so we don't always include a full kind of comprehensive battery of executive functioning, for example. So I would say in that sense, what we do is very complementary, right? And we're both clinical psychologists, so we have that in common. My training is just more specialized, beyond that into the brain function, brain behavior relationships. And so that includes, I guess the board certification for me is different than the board certification for you, because that's specifically in neuropsychology. So it's just an additional specialization, I guess you could say.
Yeah. Dr. Z, let me ask you a question, because I'd love to understand the relationship between an epileptologist and a neuropsych or a clinical psych, as part of this holistic, comprehensive treatment. We know it's more than just medication. We know there's recovery therapies, whether it's occupational therapy or speech therapy, and I'm wondering what that relationship is, like who refers who to whom, and how do parents navigate this, because part of this is helping parents navigate this kind of often complex system for their children.
That is a complicated question. As an epileptologist, so I'm a child neurologist, and then I did an extra year. I was quote unquote grandmothered, whichever you prefer, into board certification with epilepsy and clinical neurophysiology. So my specialty now, I used to see all varieties of children with neurologic problems. When I see patients with complicated epilepsy, they often have so many comorbidities that I, as a single individual, cannot possibly manage all of the different medical problems, the psychosocial problems, educational issues that it compounds. So if you're really going to work with complicated, or in an epilepsy clinic, you need a multidisciplinary team. And we actually wrote a grant and documented that if you have a multidisciplinary team, which includes nurses, nurse practitioners, myself, neuropsychologists, clinical psychologists, pharmacist, dietitian. I mean, we're talking about a village here, social worker, God help me with if I didn't have a social worker, that we were able to speed up the time to epilepsy surgery in appropriate candidates. And we dropped the number of emergency room visits and hospitalizations by over 90%. And we took it to insurance companies and said, for an extra $100 per patient per year, this is what we could provide you. And they didn't bite, which was incredibly disappointing, but not totally surprising. So I think I see it as a team effort. And parents are under so much stress when they have a child with a medical condition, but particularly epilepsy and things that affect the brain. That just the brain is so vulnerable, and it affects, as you explained, Dr. Brenner, their personality, their emotional regulation, in addition to the educational and then, of course, the developmental aspects, that it turns their life upside down. So without appropriate supports, it is really complicated. So I see myself as making the medical decisions actually in a pretty straightforward manner. If all I had to deal with was medication, surgery, vagal nerve stimulator, other neuromodulatory devices, I'd be fine. But I spend most of my time in clinic in helping bring in the necessary resources, including neuropsychologists, clinical psychologists, dietitians, social worker who can help with sort out the complicated insurance and financial issues that are dealt with. Because without those supports, I can write a prescription. It may not be able to be filled because the family can't afford it, or their insurance company says, oh no, you have to do X, Y, or Z medication. What Dr. Zupans has prescribed isn't appropriate. So it really, to coin a phrase, it does take a village. And I may be at the titular head, so to speak, but without the arms and legs and the body, I don't work very well. I need everybody to join in and really support parents and their families, or care providers and the patient and their families. Without those supports, my medical decisions, I think, are for naught. So that's how I see. And I think oftentimes I may not think of something, and the neuropsychologist or clinical psychologist would say, this patient really needs counseling, or this school system is not doing enough to help this particular child. So there are a couple of things that stuck out to me when I was listening to Dr. Brenner and Dr. Mary, is we need to help parents and be proactive and buttress them. And so our neuropsychologists will often call into the IEP programs when the individual educational program is being developed in a school system, because they carry, you all carry weight. You say, no, this isn't appropriate. I said in X, Y, and Z that this is what this child needs. You can't just put them into a classroom like this. They are not going to thrive. And then I also liked what struck me, as you said, how to emphasize the positive, because parents they can't always be told, oh, your child has epilepsy, and now your child has intellectual disabilities. Oh, your child may have autism. You're just it just weights you down. So to be able to emphasize the strengths and build on weaknesses, I think really offers families hope. So that's a really important part of our teamwork, is to show parents that look at all the strengths that your child has, and we're going to build on those weaknesses.
I appreciate that, Dr. Z, so much. I have a child with autism. He's lower on the scale now, but when he was 2 years old, he was pretty high on the spectrum. And we were resourced, and we did a lot of homework about, what school to put him in, what place would allow us to have an IEP that was responsive to his particular challenges. They allowed us to bring an occupational therapist, a speech therapist right to the classroom. And I think that's a good pivot point to, the idea of individual education plans and the role that both clinical and neuropsych, evaluations play in helping that child be given the best opportunity for success in the classroom and in the educational environment overall. And I'd love to get both, Dr. Mary and Dr. Brenner's kind of perspective on IEPs and the interplay between, what you do, what the school does in response, and what, parents can do to really push that forward and make sure, that child is really advocated for, because that's what we're after here.
I can start because I'm so glad, Dr. Z, that you brought up the idea of having an advocate, like a psychologist or a neuropsychologist, to participate in the planning of the IEP. I was hoping that topic would come up, and I think special education, and I always have this conversation with families, is that special education and the right to, a free, public, appropriate education is a right. And so helping parents understand that their child's needs, they're entitled to have those needs met as part of their educational and intervention programming. And I think obviously most schools want to provide good services to the children that are there, but sometimes having an advocate or that is part of a local organization or a clinical neuropsychologist or a clinical psychologist or a neuropsychologist who can join and help empower that parent and encourage that parent to ask for what their child needs can be really powerful in making sure that their child's special education needs are met. So, I really like the idea of empowering parents, helping them understand what their child needs and encouraging them to advocate for those services as part of their child's educational programming, whatever those needs are.
Yeah, absolutely. And, I think, Dr. Mary, I think you've probably experienced this in your practice as well, but some of these children are considered by the school system to be untestable, so they haven't been evaluated. And then the plan is based around assumptions about what the child needs. And so it does sometimes take a specialist who can evaluate a nonverbal child, who has the training and the tools to be able to provide characterization of what that child can do. I've seen this so many times where the education plan was well-intentioned, but was not a good match for what that child actually could do and what that child actually needed. And so, even just having those data and having the conversation with the parent, giving them a few talking points to help when they go back to the school. Certainly there's also, we're equipping the family with a report in writing that they can share with the school. I wish that everybody at the school read that report verbatim and took notes. But again, I think that's where the conversation comes in and being able to connect with the school and talk to them and answer questions as they come up. But I think a big part of this is trying to give the family, communicating to the family in a way that they can really own this information so that they have a couple of key points that they can make when they're advocating for their child.
Yeah, you're absolutely right. I think I have that conversation every day, at least once a day, about the idea of matching the intervention programming at school to the child's level of developmental functioning. And I talk about our schools, like they're academically focused and that's their role. Sometimes I think our evaluations are more comprehensive, more developmental, more medically focused. And so we can offer some additional recommendations for those, for interventions or supports that would be helpful for a child that might not be in the sort of parameter of academic intervention. So I think the evaluations can be very, very complementary, the school assessment and then the medical evaluation. And we're just providing some additional recommendations for developmental functioning.
I'm going to put both of you on the spot real quick and ask, if I'm a parent, is the school's testing enough? Mm-hmm. Because I think that's important. The schools offer testing. They offer their own kind of advice and in some ways, it's well-intentioned advice about what an IEP might look like, what accommodations versus adaptations or a combination of two might like to be responsive. But if I'm a parent, can I reasonably rely on the school's testing, evaluation, assessment to be as impactful as, what you guys do on a day-to-day basis?
I can take that one to start. I think a simple answer to that is that it can be enough. I think there are situations where that's sufficient. I think for the types of patients that we see with epilepsy, it's rare for that to be sufficient.
Yeah, I think that's a great answer, actually.
Yeah.
I was
An
thinking,
artful
what could
answer,
I
yeah.
add to that? And I'm not sure. I think that's exactly what I was thinking.
That the
What are
challenge
examples? Go ahead, Dr. Z.
the
Go ahead.
challenge that the school system faces, because I know many teachers, and I became very familiar with the school districts in California, I was at the University of California, Irvine, before I moved back to Wisconsin, is that the budgets for school systems have really been pared back dramatically. And so I think what you said, Dr. Mary, I believe, was schools really try to, they have the best intentions, but oftentimes they are not provided with the adequate resources to really give individual children the services that they need. And I think they feel badly about that, and they're trying to do the best that they can. And but that's where I'm very happy that school is, at least in the state of Wisconsin, all the school referendums that were for increased budgeting to public school systems passed in this recent midterms election. And I was very pleased to see that, because you can only cut back so much. And then you really begin sacrificing not just the education, but the psychosocial welfare of these and emotional stability of these children.
So where are the challenges for parents? I'd love to hear, the entire panel's perspective on, like, what are the blind spots? What are the challenges? What are the obstacles? Because, like, listening to you three, it's almost intuitive that the work you guys do comprehensively provides the best opportunity for a child to be advocated for and to be given the best opportunity for success. But if I'm a parent navigating this, like where are the pitfalls, where are the blind spots, where are the obstacles to be able to provide this kind of team approach to a child being treated holistically?
One thing I see a lot is that a school will say no. This is related, I think, more to the previous points, but also speaks to obstacles. But a school will say no to a particular request. And so and oftentimes, I think one approach to that is to dig in your heels and keep fighting for that one thing. And another is to say, wait a sec, what can you give me that would meet my child's need? So this is the child, being very clear on what the child's need is. So if you can't give them a one-to-one aid, how can you keep them safe in your classroom? So, I think there is room for flexibility, even when schools may not be able to provide the ideal, going in with that attitude of, okay, so how are we going to meet this particular need? And what are your ideas? What creative ideas do you have? And really pushing the school to think flexibly about what they can provide, so that we're not stuck at an impasse, which, and maybe it is a place where you do need to bring in legal consultation. So, there are times where it's worth fighting the fight, but there are other times where I think just appealing to the school's desire to educate the child, and assuming that they also have the child's best interest at heart. They're just limited by lack of resources, but really pushing the team in that IEP team meeting, really pushing everybody to be working creatively to try and problem solve, I think is well worth everybody's time and energy.
I would say it reminds me of, I'm going to send you to Congress, because we need minds like yours who could say, instead of butting heads, can really say, okay, help me understand why you have taken this position. That was taught to me one time through when you have difficult conversations, sometimes an icebreaker can be, help me understand how you came to that conclusion, or how can we work together to reach a consensus, because that works better with school systems than hitting them on the head saying you must provide all these services, because then they just, my opinion, they just really push back. What do you think, Dr. Mary? I'd be curious.
Yeah, I love that idea. I think the idea of really understanding what your child needs, I think the more that we can help parents understand that, the more that they can participate in that discussion too and offer suggestions. Well, if that doesn't work, well, asking the school what they could provide, but also saying, okay, well, here's another option. Can we make that work? And I think the more that parents understand the testing and what their child needs, they can really advocate with that knowledge. I was thinking encouraging parents to ask questions in those meetings. Again, in that effort of understanding the testing, there's a lot of testing that happens, here or at the hospital and also at the school. And I think sometimes those IEP meetings are really intimidating, especially if there's just one parent there and there's, 5 to 10 professionals from the school district. It can be really intimidating to say, I don't understand what you're saying, or repeat that. But I think that can be so helpful in helping, your child getting their needs met, because then you can be an active member of the team. And, it's their job and their responsibility. And I think their desire for parents to understand the results of the testing. So don't be afraid to ask questions and take as much time as you need to make sure, that you're understanding what your child, the way that the school is describing your child and why they're offering the recommendations or interventions that they're offering.
I had a flashback while Dr. Mary was talking with my oldest son, who was diagnosed ADHD in 8th grade, and he was going through high school. The conversations around IEPs became increasingly harder. There were more students, same resources that were there for middle school. And I remember being at that first meeting as a parent with his mom, and I think they had 14 people in that room, including the teachers, which I was impressed that they had the teachers in there so they could provide specific feedback, share their experience of my son, share their experience of his learning ability, what he did well, what he didn't do well. So it was a robust conversation. But, I've been a legislator. I've served as executive director of nonprofits. I've been vice chair of a level 4 trauma center. But that environment, especially because you're advocating for your son or your daughter in that way. And my son didn't have something catastrophic or potentially catastrophic like epilepsy. And it was intimidating and it was hard. So I appreciate that perspective so much, Dr. Mary, and really to help parents understand, hey, it's okay to ask questions. It's okay to pay attention to that mama bear, papa bear instinct and really advocate for your child. And it's not always going to be comfortable, right?
And you can
in some
bring
cases.
A friend. Oh, sorry.
Right.
Yeah,
No,
please.
You can bring whoever you want with you, even if it's just, your neighbor or your best friend. And sometimes just having, someone that you trust and that, is there supporting you can be really helpful in those meetings too. It can't be a parent advocate or, a professional, but it could also just be a friend.
And think about how intimidating it is, because the patient population that I've worked with at Children's Hospital of Orange County, 60% were medical assistants, many of them Hispanic. English was not their first language. The majority did not have a college education. They really struggled with the language. If you're a parent, and then they'd have to take a day off from work, and of course they wouldn't be paid during that time because they didn't work in an institution that provide medical family leave. So here, if you are in a room with that many people, English is not your first language. You feel intimidated because maybe you didn't have a robust educational background. Intimidation, oh my gosh, these parents, they do not feel empowered. So I think your suggestion, Dr. Mary, of having a friend, a neighbor, any kind of advocate with them is important for a couple of reasons. First, it's a show of force of someone, and then second of all, when you go into a conversation where you're really stressed and intimidated, you walk away and it's like a tabula rasa. You maybe remember 5% or 10% of the conversation. And so having another person down who could even be a scribe as well as another set of ears is, I think, crucial and really important. It's just, I often wanted to go to these IEPs because I didn't have the time, obviously, but I just felt so badly for these families and their children, because I personally would be intimidated.
Yeah, that's a great point. And by the way, we can do a whole series on access and language barriers and cultural barriers and socioeconomic barriers, and I think that would be a very robust conversation in and of itself.
Yes.
Throughout the country, as we see the kind of ethnicity of the country continue to increase in diversity, and how the institutions that are meeting the needs for these families aren't necessarily evolving as quickly from a multicultural diversity perspective. So even the idea of feeling comfortable with the person, your peer that you're talking to, can be a topic, I think, of robust conversation. At what age, we haven't kind of got into, at what age do we start this process for parents? So theoretically speaking, I have a child with pediatric epilepsy. Let's say something complicated like infantile spasms. He has gone through, assessment, diagnosis. He's on a treatment plan. He's responding well to treatment. At what point do I introduce the need for the kind of evaluations that we're talking about to aid not just the school, but the parents and the epileptologist that's at the top of this kind of treatment family, if you will?
So I would say at the time of diagnosis. So we have strong data now showing that even before the diagnosis, the early indicators of potential problems down the line are there. So I think if this child has not already been evaluated at the time they get the epilepsy diagnosis, that's the time to do it.
I would echo that to 100%.
I agree. And I was thinking too, gosh, as someone who does these evaluations, of course I'm going to say they're valuable and you should start as soon as possible. But
well, then you have a baseline then. Right. And for me as an epileptologist, I'm not only looking at the EEG. Let's say the child has infantile spasms, they have a hips arrhythmia pattern, which is this chaotic brainwaves. And that can really guide the efficacy of therapy, because infantile spasms can be very subtle, or infantile spasms can disappear. But if the chaotic brainwaves, the hips arrhythmia pattern, doesn't go away, developmentally, that child's not going to do well. So it can help guide therapy, but you have a baseline, and this child is going to be at risk for autism, for significant intellectual disabilities, developmental delays, perhaps emotional dysregulation. So being able to track that and offer advice early on, particularly in the early stages of development, we know the interventions can be effective. Oh, that's golden, in my opinion. Really like that.
I'm glad you weighed in with that, Dr. Z, because my next question was going to be, how do you use that information? We've talked about how a parent can use that information, how a school can use that information. But as the epileptologist, my follow-up was going to be like, how do you use that information? That's Dr. Brenner and you share a patient, or, Dr. Marin, you share a patient, they have their evaluation, and then they, I assume, have kind of periodic monitoring to see, how that child develops. How do you then take that and factor that into your own treatment protocol?
Are you addressing me on this one, or?
Yeah. No, you, yeah.
There, certainly I want to see a normalization of the EEG if possible, and an elimination of seizures. And usually then you will see a dramatic improvement in the Neuro-Psych profile and the psychological profile of that child. But we also sometimes give medication that can have side effects and affect the apple cart, and toss things up. So some of the medicines that we provide may aggravate an underlying condition, like can create sleep disturbance, or make a child who's hyperactive even more hyperactive and inattentive. So there's always this balance of our treatment plan with how the child is doing from a developmental aspect, academic advancement, and emotional regulation. So that's how I would use the information. And I rely very much on clinical psychology and neuropsych to help guide me in my decisions. I
appreciate that.
We're
wrapping up.
Family, I should say. It's not really my decision.
Up this really important conversation, and keeping in mind that our audience is parents and helping them prepare what to expect on this journey that certainly isn't a straight line all the time. as they advocate for their children with epilepsy. What one piece of advice, I'd love to hear from each of you on this, maybe starting with Dr. If you can only offer one advice to parents with respect to this conversation, what would that be?
My piece of advice would be to feel empowered. Don't be afraid to ask questions, and to be in partnership with the other care providers, meaning the medical team, the psychological team, and the neuropsych team. Not to be afraid to be a part of that team. Don't be dictated to, but be a part of the conversation.
Dr. Brenner?
Can I have 1.5 things?
Sure.
So first, I think listen to your instinct. So parents have strong instincts when they feel like there's something not, that their child is taking longer to learn something, or there's something that seems different in how their child is interacting with others. Listen to that instinct and take action early. So, sometimes there are wait times for neuropsych. In a perfect world, it would happen right away. But you can start the process with the school simultaneously. So ask for an evaluation with the school as soon as you have a concern. And if you put that request in writing, they have to initiate that eligibility evaluation. And that should be started as soon as possible, because it can take some time to get services in place.
I would say intervene early. I think there are times when development is a moving target. So as kids are young, if they're already a little behind, there's absolutely a chance that they'll catch up and their development will be closer to on track, and that will be great. But for some of our kids, especially with particular conditions and syndromes, we know that they're at risk for developmental delays. And I think sometimes there's a focus, especially for kids with seizures, on seizure control in early childhood, which is, of course. But also I encourage parents to, development is happening or not happening. So the idea of being proactive or intervening or seeking out those intervention services as soon as possible, I think is really important to producing best developmental outcomes. Or if your child catches up, then great, they're advanced. But the idea of really intervening early and not waiting is the advice I would say.
Yeah, the consistency between the three of you is start immediately. Start immediately, ask questions, lead the team where needed, and listen to the team where you don't have the expertise and it fits within your kind of parental instinct. If something seems off, chances are it is. Your child better than anyone. You
Absolutely.
get to see him or her every single day, and no one is going to advocate more for your child than you will. So I would like to paraphrase the answers by saying start immediately. It's probably too late already if you haven't started and you have a child who's starting to show signs of the things that we're talking about. And be part of the team, lead the team when needed, and really ask the important and sometimes tough questions that need to be asked as you advocate for your child. And I really want to tip my hat to all three of you. You're all so talented. You all work so hard. You show so much passion for the children you guys get to work with, and on behalf of Mickie's Miracles and the families we get to advocate for, our medical advisory board, and the work that we do, we sincerely thank you for your experience, for your expertise, and the passion with you deliver that expertise and experience. And I want to remind everyone at home that Beyond the Diagnosis will be available at mickiesmiracles.org. This is the second of a 3-part series to help parents what to expect on the diagnosis. And all these episodes will be available at mickiesmiracles.org. Dr. Z, Dr. Brenner, Dr. Mary, thank you so much for this robust conversation. Thank you for your transparency. Thank you for your insight and for helping us prepare parents for what they can expect beyond the diagnosis.
Thank you so much for having me and for bringing us together. Thank you.
Yes, thank you. It was really a pleasure. Pleasure to meet all of you and interact with all of you. Great ideas were really brought to the table today. Hopefully
Thank you.
it'll be helpful to parents.